Hi, I'd like to talk today a little bit about hydroxychloroquine. This drug has been in the news. There's been a lot of controversy about it. I've been kind of ignoring it until a couple of weeks ago. Dr. Stella Emanuel was in the news. Evidently, she's a controversial physician who reported that she'd had success with it. And what I didn't quite understand at the beginning was this was enormous pushback against this in the news. So I looked into it. And first of all, Dr. Emanuel, whatever you might think of her external hobbies, one might say, she is a physician, a practicing physician in America, and all the places that I read that she was not a physician seemed like a unnecessary attack on her actual credentials. She's a working physician, she's licensed in America, she's a doctor, but irrelevant because there's been not just one doctor, which I would say is just not really enough data to decide on, but many physicians have reported a lot of success with this, and it's been really argued against in the news. And I thought, I don't understand this, so I want to look into it. And on that note, I would like to show people a little bit about what I've discovered about hydroxychloroquine. Now, I'm getting a slideshow ready. I have some slides and start from first slide. So now I'm going to have to turn the camera because I know a lot of people do these cool, picture in with the screen, with the slides, but I don't really know how to do that. So I'm going to turn the camera and let's see. Here we have a focus on this. So I also said, look at the date, July 31st. This was the day that I was planning to record this, and then we had flooding and power outages, and so this is very delayed. I actually really want to just get this out there, so apologies for any confusions that I might have, because I haven't actually looked at these slides in over 2 weeks, but just want to get this out. So actually, let me go back to the title. So I want to decide, based on research that I did, that anyone can do, just looking at stuff on the web, what am I learning? Here's my hand. You can't get my face, but at least you can get my hand. Okay, so here's some history for people who like chemistry. I'm one of those people. So hydroxychloroquine history in 1 second. There were molecules called acridines were discovered to be antimicrobial and antimalarial a long, long time ago, over 100 years. Then there was a shortage of these molecules, and chemists invented hydroxychloroquine to fill in for those shortages during World War II. So this drug's been around since 1934. Now, there's been a lot of talk about using drugs for off-label, but I was able to find in many places in the web, including textbooks, so this is well known for decades, that there are many, many successful off-label uses. It's hydroxychloroquine and its friend chloroquine are used to treat inflammatory diseases, lupus, sarcoidosis, rheumatoid arthritis, no problem. It's known to be given with anti-cancer drugs, and it actually potentiates them. That means it makes them stronger. So that's sort of awesome. Let me center this a little bit better. Okay. It reduces cytokine concentration, which you, listener, may have heard of in terms of cytokine storms, which means it can block them, it can make them weaker. And it's well known, actually, to be an antiviral. Many papers across the web against many different viruses, including viruses called flaviviruses, there's all different kinds of viruses, coronaviruses, oh, it sounds familiar, herpes, hepatitis, and that the year is there because there's a paper that you can find on the web. Just look up hydroxychloroquine hepatitis A and that year. Zika virus and HIV. These have been tested and approved for use. It's not the only drug you'd want to use, but it helps reduce the viral load in all these different viruses because it acts as an antiviral, and this is known. So, okay, that makes sense to me. Its safety has long been recognized. The side effects that I've read about in the news, and probably you have too, about heart, and they're listed on another slide, but heart malfunctions, I guess you'd say, and other problems are recognizable by physicians, reversible, which is interesting because some side effects, by the time you have the effect, something irreversible may have happened with some drugs. For example, there are antibiotics that have something called ototoxicity, which I've read about, and by the time you're losing a little bit of your hearing, which is what ototoxicity is, you often cannot reverse it. So there are side effects that can't be reversed. These are reversible, and they're very well known, right? Which means your physician can find them, and they usually occur at the higher dosages, which is generally true for all side effects. A lot of times the reversal will happen if you don't change the dosage, but you just give the drug a different way. So some of the issues that you may or may not have read about that are known to occur with hydroxychloroquine, very well defined, things with your eyes, retinopathy, ocular toxicity, nausea, depigmentation of hair. That's interesting. If you want to be a blonde, I don't know that this is the way you want to do it, but people don't like it, and it's a side effect, and it happens. It affects melanin production. You could get pain just from taking this drug, which I would say, doctor, when I do this, it hurts, to stop doing that. So it would stop the drug. Ototoxicity, there it is. Reversible, though. Pruritus is itching. Right? There's a whole bunch of stuff here. You can read it. And then there are very rare, actually, I would just say rare, aplastic anemia. Well, that's very rare. Leukopenia, these are blood things. Heart rhythm issues, which is what you may have heard in the news, and cardiomyopathy. Those are bad. It's very good that they're reversible. They're well known and they can be monitored for. They're also all relatively rare. So, okay, so it's a good thing we already know how to dose hydroxychloroquine because it's been around for decades. For viral infections, and this I'm just citing from things I've read on the web. I don't know this. I'm not a physician. I'm not claiming to be a physician. I looked it up. I'm reporting what I read. So for viral infections, and by the way, please, listener, look this up and verify it for yourself. I'm not asking you to take anything here because I say so. That is just silly. You never want to do that. You're going to want to look at this, go to the web, look it up. So for viral infections, dosage can be calculated by weight, as is true for many drugs, and standard dosages have been determined for both prophylaxis, which is prophylaxis after exposure, or before exposure, by the way, which I didn't say here, and treatment, which means you're already positive, you're at the beginning of your illness. This is after exposure, but before you know you're ill, and you can also take prophylaxis before you even know that you've been exposed. Just take it, which is what people in India and Africa do all the time, way before COVID was ever even heard of. Hydroxychloroquine is shown in the literature. It does not help much if you already have a high viral load, which means you're already sick, pretty sick. You have to take it at the beginning of an infection. This is not really a problem. In fact, people are very familiar with this. Tamiflu, which has been on the market for decades, everyone knows if you don't take it in the first few days, preferably, I think, I'm not a doctor, I've just read this stuff, I think it's 72 hours, it might be 48. Ask your doctor, but pretty much if you've waited too long and you've got a full-on flu, your doctor is probably not going to give you Tamiflu. It does not work when the disease is well established in you. So this is the same thing. Don't take it if you're super sick. Several studies have been done treating very ill COVID-19 patients who had already been admitted to critical care. Like, that's not how I would study this. What if you tested Tamiflu like this? You'd be like, this drug doesn't work. I'm not putting this on the market. But it does work. You just got to take it at a different time. Timing is important. I'm watching my hand on the recording. I didn't realize that it would be so emotive. Anyway, where was I? So studies have also been done with high dosage where you observe toxicities, which I was defining in the previous slide. Both of these studies, which you've seen reported in the news, are ill-designed. They're not expected to show a positive outcome. This is what you're reading in the news. Now, they're not good, so now we know you can't give it to people in critical care and expect a really stunning outcome. And you really shouldn't give it with high doses. So it's good, to have the studies. I don't know that I would do them on people who are super sick. I would probably act more conservatively, but they've been done and now we have the data. All right. So I'm going to backtrack a little bit. How does it work? So it's known how it works, and I have decided that I'm not going to give a lot of details first of all, you can read this. Second of all, I think a lot of listeners are not going to care. But if you do care, here's one of many papers that you can look up. You just have to Google this name and put a message in below, and I will put links to all these papers. If there's interest, I'll put up any reference that people are interested in. Here's a super interesting paper that just came out in August, and some previous studies actually came out in April by this group and several others. So in addition to these actions that were known and you can find in the literature for 20 years, it has been found by this group that COVID-19, that's not true, hydroxychloroquine, that's a typo, plus azithromycin, which I'm abbreviating as ATM here, acts to block the spike protein from binding to the receptor, preventing entrance into the cell. Now, I just want to back up a second. At the beginning of this talk, I said I was really inspired because I've been hearing a lot of studies of doctors giving this to patients getting better, and people still being pretty pissed off at the use of this drug. Now, all of a sudden, I'm talking about a lot of technical stuff, right? And I'm citing papers. But the paper shows why the drug would work. This is not even questioning, right? Does it work? Should we give it to people? How much? And maybe it's bad. This was not a study to show in patients to show if it worked. This was a study to show how it works. This study wasn't even bothering, well, that's not really a good word because it implies some sort of emotion. This study wasn't addressing the problem of how do patients react. It was showing how the drug works. And if the drug works and you can show it on a molecular level how it works, you can expect that it will be effective. So you've got this long-standing drug that's been on the market. You have multiple papers that show that it can block the spike protein from binding to the receptor, preventing entrance into the cell. With careful studies, I don't see the controversy in trying this drug and seeing how effective it is. In addition, because it's so safe and because, yeah, it has some problems for some very small amount of people with heart rhythms, but those are observable by physicians. A trained physician can see this and stop the drug or change how it's given to the patient. I don't even see how that's a risk. Now, this is my opinion. I am not a doctor. I am not any kind of professional. I am a citizen who has gone on the internet and looked these papers up. That is all I am doing, and I'm reporting to you what I have found, and I'm giving you citations to papers and a little bit of the logic that I have read. I just flat don't understand. So, you want my opinion? If it was up to me and the doctor said, do you want to try hydroxychloroquine? I would be like, heck yeah. Yes, I do. This is from the paper that I just cited. I like it because it's pretty. Basically, what it shows, the idea of this paper is that both azithromycin, the antibiotic, and hydroxychloroquine act together to block the spike protein, which I'm sure you've heard of, right? That's the protein on the surface of the coronavirus that makes it look like a little crown, and it's all spiky, and that protein is the key to binding to the receptor in your body that allows the virus to enter the cells. You can't have infection if the spike protein doesn't bind to your ACE2 receptors. It's the whole way the thing works. So if you block this protein by gumming it up with molecules that are sitting on it that shouldn't be there, right? That's what this drug does. It mechanically gums up the mechanism of this. Then you've got a drug that's going to work. So azithromycin we know is safe. Hydroxychloroquine been on the market since 1936. And what they both do is they bind. This is a cartoon of some proteins. Let's see, on the ACE2 receptor. And this is just one molecule showing the azithromycin. And these people did a study of exactly the molecular way that these proteins on the receptor bind to the drug. So it sticks on these three protein amino acids happen to be on the tip. You really only need to know this just sits on the tip of the spike protein. The spike protein's like going, I can't bind. What's going on? I can't bind. I'm all gummed up. It's kind of like this, right? I can't work. Where can I bind? I can't do it because this molecule is strangling me. So I don't think it's really that funny, but it's something like that. So the hydroxychloroquine also binds to the spike protein at a different location, and the two of them together just gum up the works. I don't know how to say it any clearer. This is observed, okay, in these studies, and I encourage you to just read the paper. So now we're back to studies that were actually done in the clinic. Significant viral load reductions have been reported. So I am citing papers now. This is a title. You can look it up. Results of an open-label, non-randomized clinical trial. Here's the reference. This paper was cited almost 2,000 times. A lot of papers that have been cited, however, that show the effectiveness of hydroxychloroquine are cited as low as 13, 22, 17, 15 views, which is a little crazy because the whole world should be looking at these papers. So I don't really know why some of these papers are not getting any citations and not getting a lot of views. Now, I know what you might be thinking, which is a pretty safe statement. I know what you might be thinking. There's a lot of studies that also show that it didn't work, right? So why are these studies any better? I say read the studies. If the studies are not properly performed or on a very small set of patients, then I would say you can weigh them, but you want to weigh all the things together. You want to weigh together your understanding of the studies that work and your understanding of the studies that don't work. By the way, this is important, and I know you're not going to want to copy it, so anyone who wants to see this, I will put the link in the comments. But this is a list of hundreds of citations at Google Scholar on these studies. Okay, a little bit more. So there should be a slide in here that also discusses, oh yeah, and this is it. Okay, so you want to read the literature and look at what other people think is the right dose. You want to look at what people are using now in studies that have worked, what they've used in studies that don't work, and what they've used in the past for other viral studies. So your goal is that it treats the disease and you have no or few side effects. So that usually means you want the lowest dose possible. And the dose will differ for what you want to do. For example, for prophylaxis of malaria, people take 1 pill a week, and I'll mention that again in another slide. 1 pill a week, right? That's a really nice low dose, low burden on the body, effective. People take that for years, decades even. If you're treating malaria that you have, you're going to want to take a much larger dose. And then there's doses that are known and have been worked out for decades on treating lupus, treating rheumatoid arthritis, and other what's considered off-label uses that people also take this drug for decades. I mean, people with rheumatoid arthritis have it from onset, maybe the rest of their lives, could be many, many years, and they take this drug. So in general, studies have shown, and going all the way back to the 30s, but over time, you generally want to prescribe between 5 or 7 milligrams per kilogram, which works out in general for people between 200 milligrams to 500 milligrams a day. It's a general dosage of safety and effectiveness for hydroxychloroquine over many diseases. If you're a small, thin person, you're going to lean towards this end of the spectrum. If you're a bigger person, you lean towards this end. But they're both efficacious. If you're little and you're not having good response, you can take up to 500 milligrams a day. So here's some doses that we know. Lupus, 200 to 400 milligrams a day. Rheumatoid arthritis, 200 to 600 milligrams at a max. But there's more. This is really interesting. The FDA themselves states that hydroxychloroquine is safe to prescribe for children and pregnant women. That's not true for the vast majority of drugs. And if they are safe to prescribe for children and pregnant women, you usually want a much lower dose. Turns out that both these kinds of people, pregnant women or children, can take up to the full adult dose. So that's pretty safe. So let me look at this. So here's a study that was well reported, right? Azithromycin 600 milligrams a day. This is the dosage. And why am I reporting azithromycin? I think I mixed some of these up actually. This is chloroquine. So it was a high, I'm very sorry. So this is chloroquine. It was a high dose of chloroquine for 9 days, 600 milligrams, and you take 2 on the first day. And then a low dose for this study was 450 milligrams with 2 on the first day. And however, it was given to people who were already sick and 5 days at minimum and more over onset, and the conclusion was negative. So I would say it was a high dose, which is uncomfortable for the patients. Not out of the range, just a little high, but they were already sick. So I would say I'm not surprised that that's negative. Here's a French study that was also highly cited. Again, hydroxychloroquine, 600 milligrams on day 1, then 250 milligrams, which is a much lower dose, but it was given to 4 times a day. I'm sorry, so that would be 1,000 milligrams. That's actually a very high dose. These are very ill patients, and the results were not good. Okay, again, you're doing a study with really sick people, like Tamiflu, not good conditions to test this drug. There was a Chinese study, super high, right, 1,000 milligrams a day for 10 days. The people were treated right away. In this study, there was 100% recovery. And then the CDC did 1,200 milligrams a day times 2. That's usually day 1. You want to take a high dose, and then 800 milligrams a day for 12 more days. And they claim it no harm and no benefit. This study, when I read the report, it was unclear if they gave it to people who were very sick or not too sick, or a mixture. So this study is very difficult to cite, and all of these studies are available on the web. So if you want what I've distilled from the literature, it looks like, here's the range. Hydroxychloroquine, you want to start at between 500 and 600 milligrams a day on day 1, and 400 milligrams a day for 5 to 12 days, immediately upon exposure, not in critically ill people. I would mix it with the ATM, the azithromycin. I really apologize. Again, this should be hydroxychloroquine. So it's hydroxychloroquine plus azithromycin for the reason that was given in the paper that I showed earlier. I think that's a very important finding, that they act together in a synergistic way. You want to add zinc supplements. It's been super well studied that zinc potentiates the activity of these drugs, and that even zinc on its own can help you fight off COVID. If you are being exposed, for example, we're all under this lockdown because we might be exposed. So during a risk period such as now in the world, everyone in the world can take between 250 to 400 milligrams per week. That's 1 tablet per week as a prophylactic, very inexpensive. Here are the names, some names of some doctors that have reported very good results from using hydroxychloroquine with azithromycin. This is not at all extensive. I just got tired of looking up names. Right? These are doctors that have tried to tell the media and have been either taken down off YouTube or called crazy or somehow or another shut down or been admonished by the CDC. All these doctors, many more, you can look them up yourself. Here is a website that has citations to physicians that are doing this. And this is an article. Whatever this link is, here are 5 doctors whose patients have seen recovery with hydroxychloroquine. Just go to this link and read that article. The point of this is to tell you that there are many physicians that are trying to report that they've had really, really good effects with this medication. And that information seems to be ridiculed, if not pulled off the web. And again, based on the little bit that I've said here and what I've read on the web, I don't know why. So reports of success are labeled disinformation. Okay, so I don't understand. So I'll start here. I really just can't say anything about this. You got to look it up. Misinformation related to COVID-19 pandemic. In this article, hydroxychloroquine is listed as useless, and misinformation that has ever been out there that it's effective is just incorrect. That's Wikipedia's article. And it doesn't match anything that I've read on the web. It doesn't match any of this information that I unearthed on my own. I don't understand it. So I just wrote, I can't understand it. I can't condone it. I can't figure it out. I can't. This is a fact, right? Many healthcare workers in India and South America routinely receive prophylactic doses of hydroxychloroquine, as well as their families. If a healthcare worker is exposed at work, they get a little bag of hydroxychloroquine to go home and give their families for a month, 2 months, whatever. You don't need a prescription. In these countries, hydroxychloroquine is available over the counter. You go into your corner drugstore, you pay $2 or $3, you get a box of hydroxychloroquine, and you take it. These people have been taking it for decades already because these are places where there's malaria, and people take it prophylactically as well as during an infection to prevent infection with malaria. They just take it. They don't worry about it. They don't get sick from it. They take it, and the incidence of malaria is decreased. Now, I get that nobody is complaining that it's approved for malaria. What I don't get is why something so safe that has a known antiviral activity specifically against coronaviruses in the past, SARS and MERS, in the literature since 2010, why that would not be appropriate to use now. I literally cannot figure it out, which is why I'm making this video. And I'm hoping that maybe somebody can either enlighten me or support this and say, yeah, I think we should try hydroxychloroquine. It can't hurt and it could help. In the USA, now I have to remember I made this before big power outage and stuff. Why did I write this? 383 deaths per million. Because these numbers are stunning. So this is the approximate number at the time that I collected this information, which is now 3 weeks old. So this is average across the country. We all know every state has different numbers and different averages, and they vary a lot. So this is an average, 383 deaths. India, with a population of 1.4 billion, is clocking in at 11 deaths per million. Their incidence is very low. This is reported in several places on the web, and there are graphs of this. India uses hydroxychloroquine widely for malaria, and people there were already taking it before the COVID came along. So if it's in their blood and it's effective, it's going to bring the caseload down. And in fact, that's what was observed, 11 deaths per million versus 338 deaths per million. Lupus patients, right, in America and anywhere, people who are lupus and who are being treated, I left this part out, who are being treated with hydroxychloroquine have a very low incidence of COVID-19. I would say that's the same mechanism. If it's in your blood at any dose, it's not going to allow you to proceed with the mechanism for the reason I showed earlier. Remember, spike protein, muzzling it doesn't bind. The hydroxychloroquine, it doesn't really bind at the tip. Remember I said that? That was exactly where the azithromycin bounds, but it kind of binds near the base. My understanding from the literature is it binds to the base, and it still impedes the entrance of the virus from binding to the receptor, to the ACT receptor. This is my really bad model of the extra molecule. Here's your nice little receptor. Spike protein, and now we're gumming it up, right? It's got a different shape. It's not going to be able to bind. That's how one of the many proposals that just so that I don't leave people in there with the idea that it only works by gumming up the system. It also is known to reduce the pH in the receptor as well, so that when the virus, if you've taken hydroxychloroquine and the virus gets to the cell, there are things called endosomes in the cell, and the endosomes have hydroxychloroquine in them, and it changes the acidity of that, and so the virus may penetrate, but then it's in this acidy environment, and it can't thrive, and it's killed. That's one of the ways. Another way that hydroxychloroquine is effective in killing many viruses. That's why it's so effective with many viruses, because it does this basic pH change when the virus starts to get into the cell, and the virus can't tolerate acid. Okay. We already beat this to death, I think. So this is pharmaceutical, right? Hydroxychloroquine will not work nearly as well if you're already ill. So I guess I'll say a little bit more. Drugs are designed to work in a specific way, so you have to understand how the drug works and how your body works. We know already that this drug does not work if your viral infection is advanced, which means the viral load in your body is high, or if your lungs are damaged by the virus, which we know is a terrible side effect of advanced disease, or if the patient has a comorbidity, which we also know is a high risk factor for this disease, or if the patient is already very debilitated or ill. Many other countries use So I don't think France is right, but Brazil, Turkey, India, and other countries are freely using hydroxychloroquine, and they've been dismissing the CDC, the WHO, and the FDA conclusions on its use against COVID-19. They're just dismissing it. In fact, there are articles on the web, if you look at international news, that don't understand why Americans are having so much trouble with this medication. The dire warnings against its use are mostly coming from the US, right? The AMA, the CDC, the FDA, and state pharmacy boards are against it. In fact, physicians are limited from writing prescriptions for hydroxychloroquine, putting their licenses at risk. Again, I don't know why. The logic doesn't follow. Physicians have generally, historically in the US, been free to use their informed knowledge and their own decision ability to prescribe things as deemed appropriate for patients. That's a physician's job, to be free to use their mind to help heal an individual patient who's in their care and they have personal knowledge of. Well, this is not being allowed due to restrictions from state governors who, now maybe they're just following the CDC and the WHO, and there's a lot of doctors there. I don't know why they're saying what they're saying. Can't figure it out. So we all say, yes, medical workers, thank you, essential workers, thank you, you're heroes. But our governors are denying these heroes access to a medication that can help them if they're exposed. They are not defending or helping to defend our first responders. And basically, I want to point out this is an unprecedented restriction throughout all of medical history of any medication or pharmaceutical. Unprecedented restriction, especially something that's not. So this should have gone earlier, and again, I apologize. What are the chances of heart irregularities in the largest study as reported in Lancet? And here's a reference so you can check me out. This is a copy and paste. 2,019 patients treated with chloroquine or hydroxychloroquine plus or minus, either with or without azithromycin. No instances of this is the heart arrhythmias, that one of them that people have observed. No instances of arrhythmogenic death were reported. That's 0. Although use of these medications did result in QT prolongation, which is another heart arrhythmia, another type. Clinicians seldomly needed to even discontinue the drug therapy. And then they said, we can do further studies on this. This is current. So this is known that the chances of heart irregularities are low. They're not 0 because every drug has side effects. That's why you don't take them like candy. But they're low. Here is a paper, one of many, July 2005. I thought this was notable. Chloroquine, potent inhibitor of SARS coronavirus infection and spread. Look it up. There are a number of papers that have been out for over a decade that show effectiveness of chloroquine and hydroxychloroquine as an antiviral inhibitors of a number of viruses, Zika, hepatitis B, and other MERS. And this paper, I just picked this one of the SARS coronavirus. It is effective against coronaviruses, and that is known. What? So here's my conclusion, and then I'll let you go to do whatever else you're trying to do today. I really hoped this would be 5 or 10 minutes. It's coming up on 35. But my conclusion is, I don't know why this drug has been vilified. Research supports its use, period. In COVID-19, research done as its antiviral properties supports its use. Please don't listen to me. I'm not a doctor. I haven't worked in this field. I have just read on the internet. I'm not claiming any special knowledge. Do your own research. Look at the articles I post. Find your own articles. I wouldn't read any newspapers or magazine articles or magazine. Just look at scientific articles. We all say that we follow the science. We follow the science, right? Read it for yourself and then decide for yourself. That's really all anyone can do now. You can research. You can research, think, and decide. Just make sure you're getting the real deal. Make sure that when you get data, that you're correlating it with studies that are accurate and not with some article or some WHO dictate that maybe, I don't know what they're basing it on. They may have, I don't even want to speculate because that will just piss off people. I don't want to Hello. I don't know what just happened. Yeah, I don't want to piss off anyone because they could just knock me down like that. I just want to say that collect the information for yourself. I hope that this was useful. I'll answer any questions below. And I thank you for your attention. I know this was a little longer than I thought it would be, but thank you for listening. And I hope it was helpful to someone. Take care.